Hello, welcome to the EKG Guy, and welcome to the EKG of the week. I hope you're having a wonderful week, and I'm glad you could join us. This week's case is a 69-year-old male with a history of coronary artery disease and hypertension, and we have his EKG shown here. Now, before we get started, let's review our approach that we've been using to interpret EKGs. So notice we have the patient's clinical presentation, our 69-year-old male with a history of coronary artery disease and hypertension, the EKG below, and on the right side, you can see the things that we're going to go through, okay? So first, there's the regularity. And what do we mean by the regularity? Well, this is where we want to find out if we're dealing with a regular or irregular rhythm, and if it's irregular, we want to know if it's regularly irregular or irregularly irregular. Next, we have the heart rate. Okay, so simply determine the heart rate, and then we want to look at the rhythm origin. That is, where is the rhythm actually starting from within the heart? Then we have the atrial, AV, or atrioventricular, and then intraventricular, or IV conduction. Okay, and there we want to look, is the conduction normal? Is it slow or not? Then we have the waveforms. Okay, and this would include all the waves, the segments, and intervals. We'll go through each one. And lastly, anything else, meaning is there anything else that we've missed or still need to mention? Now after that, we'll use all this information we gathered and make a final interpretation of the EKG. Now what I want you to do is pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go over it together. Okay, so we have our 69-year-old male with a history of coronary artery disease and hypertension, and he comes to us with this EKG. So first, we're going to look at what is the regularity of this rhythm. Well, on first impression of the EKG, you probably notice that the rhythm appears quite regular. In fact, this is a regular rhythm. Okay, so when you look here, you can tell that our intervals between our complexes are normal. Okay, so if you look from here to the next S wave, okay, this S wave to the next one, these intervals will be the same, okay, and you can do that with some other intervals up here, okay, so take this R wave to this, and that R to R interval should be the same as from this R wave to the next, okay, and these intervals from one to the other should be consistent throughout, and that's what we call a regular rhythm, okay, and if you were to measure that out, you would see that this is in fact a regular rhythm, okay, so we'll erase this as we move on to the next thing. So next we're looking at the heart rate, okay? So what is the rate of this rhythm we're dealing with? So there's quite a few ways we can do this, or at least two that we'll go over, because I think they're the easiest for you to know, especially when we're dealing with these regular rhythms. So what we do here is one way, which you can use with also irregular rhythms, is knowing that the duration of this is 10 seconds. So we multiply 10 seconds times 6. That gives us 60 seconds, and 60 seconds is 1 minute, so when we get the rate, we can get it in beats per minute, okay? So in order to find it, what we do is count the number of complexes going across, so let's do that. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, so we have 9 complexes over 10 seconds, so what we do is 9 times 6, and that gives us 54 beats per minute, okay? So our rate here is 54, okay? Now I'll give you the actual rate was in fact also 54, okay? So right on. Now how about the other way that you can do it? So the other way you can do it is by finding an R wave or some complex that falls on one of those thick lines, okay? So let's see here, where's one we can find? You can use maybe this one here, okay? We're going to count up to the next one there, all right? It's a little hard to make them out here. I apologize for that, but let's do that, okay? So you have 1, 2, 3, 4, 5, okay, and it's between 5 and 6, all right? So what we do here is we do 300 over 5.5 because it's right in that range, okay? And 300 over 5.5 is actually 54.5 beats per minute, okay? So again, within that range of 54, okay? So those are two ways to find the heart rate that I think are really easy to know, and you should be able to do it. It's not that difficult. Now, how about the rhythm origin, okay? So where is this rhythm actually originating from, all right? Is it from the AV node, the sinus node, the atria, the ventricles? Where is it actually starting from? Well, the QRS complexes here actually appear wider than normal, so that doesn't really help us telling us we have a supraventricular rhythm or not, okay? It's pretty much anywhere. But we can actually make out clear defined similar shaped P waves. So let's see if we have actually sinus rhythm present, okay? Now sinus rhythm, remember if we draw our heart out, this basic diagram, making this our right atrium, left atrium, right ventricle and left ventricle. Our sinus node sits up here in our right atrium. We have our internodal pathways come to our AV node. We have a Bachmann bundle that comes to the left side of the atrium. Our AV node then has a His bundle, okay, branches off then to our right bundle branch, and then our left bundle branch that splits off into a left anterior and a left posterior fascicle. So if we talk about a sinus origin, means that it comes from here, okay? And what we're going to do to tell if we have sinus origin is to look at our P waves, okay? Now, if you imagine, if this is where the sinus node is and everything's heading in this direction, that would mean our electrical axis is in this way, okay? So if you put 0 degrees here, all right, this would be positive 90 degrees. This is plus or minus 180 degrees, and then minus 90 degrees. That would mean that the normal axis, if it's heading in that direction, would lie somewhere in this range, and it's actually between 0 and positive 75 degrees. That's our P wave. Remember, P wave, we're looking at things above in the atria. The P wave represents atrial depolarization. Okay, if we draw out our complexes here, this would be our P wave, this is our QRS complex, and this is our T wave. Okay, so again, we're looking at our P waves, and what we're going to look now is at the leads. And for sinus rhythm, if lead 1 is here, the positive end sits there. This is where lead AVF sits. This is where lead 2 would sit, lead 3, okay? Then we have V4, V5, V6. Notice that our axis is heading in this direction. Because we have this depolarization wave heading in that way from the sinus node, we will see an upright positive P waves in those leads. AVR sits here, so everything's going away from it, and that's why we see negative, okay? So let's take a look at those leads. So lead 1, here's our P wave, it's upright, okay? That's similar in morphology. Lead 2, you see the same thing. All right, hard to make it out in lead 3, but you can see them in AVF, another inferior lead. V4, okay, our P waves, V5, and V6, okay? So again, you can make out our P waves, and then we said we want to see an inverted P wave in AVR. Here's AVR, and there's our inverted P waves, okay? And then another thing for sinus rhythm is that you want to have one P wave for each QRS complex, okay? And the P wave should precede the QRS, okay? Remember, the QRS represents ventricular depolarization, so that would be this portion, the P waves up here, above in the atria. Okay, so our P wave should precede our QRS, and there should be one P wave for every QRS complex, okay? So here's a P wave, and then we have a QRS, another P wave, QRS, P wave, QRS, this would be our T wave, and if you went through P wave, QRS, P wave, QRS, P wave, QRS, okay, so we do actually have sinus rhythm here, okay, so our origin of this rhythm is sinus. So we have a regular rhythm that's 54 beats, okay, so below their normal sinus range, which is between 60 and 100, okay, so a sinus bradycardia so far. All right, and that's where we're at. Now let's look at atrial conduction. Well, typically when we look for atrial conduction or the P waves or atrial abnormalities, we're looking at leads 2 and lead V1. Those tend to be the best leads to look at, okay? And we can see the P waves in both of these. The P wave duration here actually appears within normal limits. So normal P wave duration is less than 120 milliseconds, or about 3 small boxes. So notice our P waves here, okay? None of them appear prolonged, okay? We can see somewhat of a biphasic P wave that looks like this. Remember, with biphasic P waves in V1, the beginning portion of the P wave represents the right atrium. The terminal portion represents the left atrial depolarization, okay? So when we look at atrial conduction here, this is actually normal, okay? So normal atrial conduction. Now how about AV, or atrioventricular conduction? Well, in this case, we're actually looking for conduction delays as the impulse travels from the atria and ventricles, okay? And because the majority of the PR interval represents AV nodal conduction, we're going to look at the PR interval, okay? Now, the normal PR interval in adults is between 120 and 200 milliseconds. So that's 3 to 5 of the small boxes, okay? Or the upper range will be from one thick line to the next, okay? That would be the upper range for adults. Here, the PR interval appears within normal limits. It was actually measured at 168 milliseconds, okay? So the PR interval here was 168 milliseconds, which is considered normal. All right, so let's just look at our PR interval. Remember, PR intervals from the beginning of our P wave up until our QRS complex. That is our PR interval. This portion here, not including the P wave, would be our PR segment. Okay, so normal AV nodal conduction. Okay, because we have that normal PR duration here. So next we have the intraventricular conduction, or IV conduction, okay? And here we're going to look at the duration of the QRS complexes. Normal QRS duration is often between 80 and 110 milliseconds, or about 2 to 3 of those small boxes. The main thing we're looking for here is for IV conduction and to see whether or not it's prolonged, okay? So we want those normal QRS intervals between 80 and 110 milliseconds. And if we look here, we can actually see that the QRS interval is certainly prolonged, okay? We mentioned that earlier. In fact, the QRS duration here is 158 milliseconds, which is much beyond that normal upper limit, okay? So the QRS duration was 158 milliseconds, okay? So it's actually prolonged here. Okay, so let's take a look at that. Remember, QRS duration, meaning we're looking from the beginning of our Q wave, our QRS complex, to the end of it. Okay, that duration, and you can tell that it's certainly prolonged here. Okay, so we have a prolonged QRS interval, all right, meaning that there's slow conduction somewhere in the ventricles below down here, all right, so there's some intraventricular conduction delay, we call it, all right, so we can write that IVCD, intraventricular conduction delay. Now, how about those waveforms? Well, we said the P waves here are most likely normal. There's no significant P wave prolongation or increase in amplitude in leads 2 or V1 that would suggest atrial abnormalities. The Q waves may appear abnormal in those inferior leads, that's 3 in AVF, although there's actually a small R wave present in lead AVF. Therefore, the Q waves here are not abnormal, but likely the result of conduction delay, and we'll discuss that shortly, okay? So here's our inferior leads, 2, 3 AVF. We don't see Q waves here as an R wave, okay? So no Q wave. This would be an S wave, right? Remember, the Q wave is the first negative deflection after the P wave. This is lead 3, lead AVF, okay? And you can say these are Q waves, okay? You don't really see an R wave, and then all of a sudden there's a small R wave there, okay? And remember, to have any sort of post-ischemia or post-infarct or something has been there present, you want to make sure that these Q waves are present in contiguous leads, okay? And we don't see that here. So it's likely that these deep S waves are a result of the conduction delay that we'll soon see. Okay, now the PR segment is not significantly depressed or elevated. Okay, remember the PR segment was this portion here, all right, and there's no elevation or depression. The PR interval we said was within normal limits. However, we said that the QRS interval was prolonged, and the intraventricular conduction delay that we see here is actually a result of complete left bundle branch block. Okay, so that intraventricular conduction delay is actually complete left bundle branch block, okay? And let's go over those features here. So first, notice that we have broad monomorphic R waves in leads 1 and V6 without any Q waves present, okay? So let's take a look at that. Here's lead V6, this is lead 1. We see these tall R waves here, okay? No Q waves present. Again, these R waves are a little smaller, okay? The lead placement might be not so well, but again, no Q waves present, all right? Remember, these are S waves. When we look at Q waves, okay, so this sometimes confuses people. So let's just look at that quickly. The Q waves, we said, are the first negative deflection after P wave. In other words, here's our P wave. This would be our Q wave, okay? So P wave, Q wave, this is an R wave, this is an S wave, this is a T wave, okay? If you have a complex that looks like this is not a Q wave, that's an S wave, okay? The S wave is defined as the first negative deflection after the R wave, okay? So P wave, no Q wave present here, and so forth, okay? So just nomenclature that a lot of people have trouble with, but hopefully that makes sense, okay? So we see those broad monomorphic R waves without any Q waves in leads 1 and V6, okay? Next, we see broad monomorphic S waves in the right precordial leads, V1 and V2, with the presence of small R waves, okay? The small R waves here may or may not be present, okay? It really depends. If we have maybe an MI in that region, then we might not even see those R waves, okay? So again, let's take a look at that here. So now we're looking at those right precordial leads. So that's V1, V2, and we're seeing these small R waves that are not always present, but notice these deep S waves, okay? You can see them there, okay? So those are those deep S waves that we see. Now the T waves are a bit broad here, but they're actually seen in left bundle branch block like this, okay? They're still asymmetric and appear normal in this setting, okay? So no T wave problems here. See, they're tall, but again, they are asymmetric and normal here. And that tends to be something we see these broad T waves in left bundle branch block. Now, another point to make with left bundle branch block is that the presence of discordance of the ST segment and T wave to the terminal QRS deflection is considered normal. In other words, discordance means that the terminal portion of the QRS complex and the T wave go in opposite directions. And this is normally present with bundle branch blocks, okay, whether it's right or left. In fact, if you see concordance, where you have the terminal QRS complex and the T wave going in the same direction, this would be a sign of underlying pathology, such as myocardial ischemia. So let's look at this concept of discordance, okay? So let's just erase some of this stuff so we can get a better picture of what we're talking about, okay? So discordance is quite an easy concept, okay? So notice that you have this negative deflection S wave, okay, very deep, and then this T wave that's directed positive or upwardly, okay? So it's down and up. That's what we call discordance. Again, here's down and then up T wave, okay? You can see this in V5. All right, if you look here, this one's going up, this R wave, and then you can see the downwards T wave, okay? So they're going in the opposite direction here again, all throughout. Now, this is called discordance, okay? When that terminal QRS complex and the T wave or ST segment are going in opposite direction, that's considered normal. If you had them going in the same direction, okay, so you had this negative deflection, then imagine there's a negative T wave there, that's what we call concordance. And in the presence of a bundle branch block, that is a sign of pathology, okay? And it could be a sign that there's some sort of ischemia present. Now, moving on, we have the ST segment, okay? And you may have noticed that they're elevated and there's some depression here. And this is not uncommon with left bundle branch block. So if you look here, notice in V2, V3, these deep S waves here, okay, causing some ST elevation here. Same thing here, all right? Notice how it's above that baseline, this ST segment, or where that J point is, all right? And if you look here in lead 1, where you have this somewhat ST depression, okay? The ST segment is somewhat depressed there, and this is not uncommon in the presence of left bundle branch block, okay? Now, another thing that we can see here with left bundle branch block is a leftward ventricular axis, all right? And we certainly see that here. So let's go over this ventricular or QRS axis so you know how to find this, okay? So when we look at ventricular axis, we're going to look at two main leads. Sometimes we use a third, but I think this is a simple approach. And what we're going to do is look at lead 1. The positive end of it sits here at 0 degrees. This is positive 90 degrees. And at positive 90, we have lead AVF, okay? And then we have plus or minus 180 degrees and negative 90 degrees. Now the normal axis lies in this region in adults, okay? Usually it extends from negative 30 degrees to about positive 105 degrees, okay? And as we get older, it tends to move this leftward direction. This would be the leftward axis deviation, and this would be right axis deviation. An extreme right axis deviation that's quite rare, or sometimes referred to as that no man's land, okay? Again, you don't really commonly see that. Now, we're saying here that we have left axis deviation, okay? So let's see why we have left axis deviation. So we said we're looking at lead 1, okay? Notice that lead 1 is mostly positive, it's QRS complex, okay? So we're heading towards the positive end of that lead in this direction. If we look at lead AVF, mostly negative, okay? Meaning that if this is the positive end of AVF, we're going to head away from it, meaning that the axis is somewhere in this region here, okay? Now, because we still have somewhat of a normal range, right? We said that this region here is considered normal, okay? Now, for it to be pathologic, it has to be in this region. So this is where we're going to actually use an additional lead. And in this case, we're going to take a lead that sits here, lead 2, all right? And lead 2, if it's mostly positive, if we draw a line through this, okay, imagine this 90 degrees to lead 2. If it's positive, it'll be in this normal region over here. If it's negative on this side, it'll lie in this abnormal pathologic left axis deviation range. So let's take a look at lead 2. So lead 2 is here, and we see that it's mostly negative, okay, below, meaning that it's on this side, which means that it sits in this region here, okay? And we said this region here is beyond that negative 30. The actual axis here was negative 40 degrees. So again, beyond that normal range of that leftward axis. So we call that left axis deviation, okay? And it's more of that abnormal form. Now, do you remember what initially led us to consider an intraventricular conduction delay? It was that wide QRS complex, right? We said they were prolonged. The wide QRS complexes with these features of left bundle branch block is what allows us to call this a complete left bundle branch block. If all the criteria were met for left bundle branch block, yet the QRS interval was normal, we would call this an incomplete left bundle branch block. Okay, so because we have this prolonged QRS, that's why we call it a complete left bundle branch block. All right, if it was normal QRS, say the range was about 100 milliseconds, and we still saw all the criteria for left bundle branch block, we would call it incomplete left bundle branch block. Okay, now just so you're aware of some of these causes that we can see with left bundle branch block, certainly hypertension as well as coronary artery disease are some of the two most common, okay? And as you can see, that's exactly what our patient has here. So again, that kind of clues us in, knowing the patient's history can help you out. Now, other causes of left bundle branch block include dilated cardiomyopathy, rheumatic heart disease, infiltrative heart disease, among many other benign or idiopathic causes. Now, the QRS amplitudes here appear quite large, so we need to figure out if we're dealing with any sort of hypertrophy, okay? Now, diagnosing hypertrophy in the setting of bundle branch blocks can actually be difficult. However, it's not uncommon to have left ventricular hypertrophy in the presence of left bundle branch block, okay? And that's why we want to make sure we're not dealing with that. Now, there are some proposed criteria in order to diagnose left ventricular hypertrophy in the presence of left bundle branch block, and one of them states that if the S wave amplitude in lead V2 plus the R wave amplitude in V6 exceeds 4.5 millivolts, or 45 of the small boxes, then there is an 86% sensitivity and 100% specificity of the presence of left ventricular hypertrophy in the setting of left bundle branch block. Okay, now based on this criteria, we actually don't have left ventricular hypertrophy present. All right, but I want to go over it, because if this was present, that would mean, because it's 100% specific, that means if the criteria is there, then we're dealing with, some sort of hypertrophy, okay? So let's look at this criteria. It says that we take lead V2, okay, and we're looking at the S wave in V2, and we're adding that to the R wave in V6, and if it is greater than 4.5 millivolts, then we would have left ventricular hypertrophy in the presence of left bundle branch block, okay? So different criteria here because of that left bundle branch block present. So again, let's look at this. So if you look at V2 and V6, all right, we're looking at the S wave, so from this point to the bottom of it, and then we're looking at the R wave in V6. Now, I had a chance to go over this before I prepared this for you, and I went through it, and I found that this S wave here is actually 28 small boxes, or 28 millimeters. So that would be 2.8 millivolts. Okay, so if we add that to what the R wave amplitude here is in V6, this was actually about 3 millimeters. So we can put 0.3 millivolts. Okay, and if you add that up, you get 3.1 millivolts. Obviously, this is less than what we need of that 4.5 millivolts. So again, we don't meet that criteria. Okay. Now, lastly, with the waveforms, we have the QT interval, and again, that appears normal here. Okay, so that's it with our waveforms. Now, is there anything else that we're missing? Okay, we're actually in this section here. Now, what we want to look for here, and you may have noticed, is that there's poor R wave progression in those precordial leads. And one cause of poor R wave progression is actually left bundle branch block. Okay, so let's look at that poor R wave progression just so you understand that concept. Okay, now notice in our normal heart, okay, if we have our heart here and we put our right atrium and left atrium, right ventricle, left ventricle, and we have our leads that go across it. So the most anterior, V1 and V2, that sit over the anterior portion of the chest, V3, V4, V5, and V6 as we come this way. Again, not drawn to an anatomic scale, but these ones tend to go overlie the left ventricle, okay? Meaning that the left ventricle is the biggest portion of the heart that has the most muscle, so it will actually have the most electrical pull, okay? So we'll have our impulses that are strongest in that region. Meaning that if we have R waves, okay, if we look at them in these precordial leads, they should increase in amplitude because they're heading towards, or they're, showing that left ventricle pull, okay? So meaning if we go from V1 to V2 to V3 to V4 to V5, we should see an increase in the R wave amplitude. So here's our R waves here, okay? Maybe a slight increase in this R wave amplitude. Again, it's not normal, okay? You tend to see these much larger. You'll see the R waves higher, okay? So normal R wave progression means that the R wave amplitude increases as we go from the right precordial leads towards the left precordial leads, okay? So from V1 to V5 is what you typically want to see an increase in the R wave amplitude, okay? So again, we can write poor R wave progression here, okay? So hopefully that concept makes sense. So let's put all we went through and make a final interpretation. So we have a regular sinus rhythm that's occurring at a slower rate. Okay, we have normal atrial conduction, normal AV conduction, and then we have this prolonged or intraventricular conduction delay that we labeled as left bundle branch block. We also mentioned that there's left axis deviation, and then we saw that there's a poor R wave progression. So this is a case of sinus bradycardia with left axis deviation and left bundle branch block. Okay, so let's write that sinus brady, okay, and then we also said the left axis deviation and the left bundle branch block, okay? And remember, this was complete left bundle branch block, okay, because of those wide prolonged QRS intervals. So in conclusion, our 69-year-old male with a history of coronary artery disease and hypertension has an EKG that shows sinus bradycardia, left axis deviation, and complete left bundle branch block. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you could help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos, including both pediatric and adult courses, something I wish I had when I first started. There's also a community of over 100,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. Lastly, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.